I'm Dr. Riley.
And I'm Dr. Cook.
And today we're going to be talking about the mediastinum, specifically on chest x-ray. And fun fact, this is Dr. Cook's most favorite.
My most
lecture.
favorite. My most favorite.
Is it most favorite or favoritist? No, it's most favorite.
It's neither my most favorite or my favoritist, but we will delve in.
We will get through it. So the patient scenario today, we have a 60-year-old male. He's coming into the emergency department with complaints of dysphagia. He's got stridor on physical exam, maybe some drooling. There's definitely a few things you got to be thinking about. Vital signs 98 Fahrenheit, heart rate 105, blood pressure 135/80, satting at 98% on room air. You got to be thinking about mediastinum, especially on the mediastinum lecture. So our systematic approach is the same every time. And if you're not using our systematic approach by now, it's probably out of spite, or maybe you don't like something about us. I'm not sure what it is, but
you probably just hate us, but it's fine.
It's okay. You can hate us. Are there many lung lesions is our approach, and R stands for abdomen. There stands for thorax. Many stands for mediastinum. Lung stands for lungs unilaterally, and lesions, lungs bilaterally when you're comparing the two on your chest x-ray. And the mediastinum, just to remind you anatomically, is the area confined by the medial parietal pleuras on both lungs in that middle part of your chest.
Essentially anything that's not the lungs in the middle of the chest.
Exactly.
With the focus of the mediastinum, obviously this is included in your normal approach, but let's talk about specifics. I usually like to start on the left side of the heart/patient. I trace the left heart border, work my way around. Then I focus on the vascular structures. And again, we should know our normal anatomy so we can appreciate abnormal. And as we're kind of doing this circular approach and I'm working my way through the mediastinum, going all the way up and down and also looking into the neck, I am looking to see if I appreciate any abnormalities, which can include widening, masses, deviation, obscuration of borders, any silhouette sign. One important thing with the mediastinum is you have to obtain a lateral. You compartmentalize your mediastinum based on the lateral. So obviously very important to get the lateral. And then lastly, we're looking for pneumomediastinum. Classically, you'll see on your board exams, for example, a pneumopericardium, but that is not always real life. Some of the more subtle ones can just be air tracking up into the paratracheal region, paraesophageal region. You have some subtle lucencies in the neck indicating a pneumomediastinum. Don't forget to check those areas out very closely.
Yeah, and I just want to harp on a couple things on this slide too. The border obscuration can be really difficult to see on a PA or AP. Again, that's just emphasizing how important it is to get that lateral because there's so much different soft tissue structures in the mediastinum. So it's really difficult to distinguish one from the other.
So let's compartmentalize our mediastinum. I'm going to start with this first line, which starts at the sternum, goes down the anterior edge of the trachea and the posterior aspect of the heart. The second line that separates the middle and the posterior mediastinum is going to sit 1 centimeter off of the anterior edge of the vertebral bodies. So everything in front of that first line is our anterior mediastinum highlighted in red. Everything in the middle is obviously our middle mediastinum highlighted in green. And everything behind that in yellow is our posterior mediastinum. A comment about the compartments of the mediastinum, you might see a different way of organizing the mediastinum. There are multiple different theories or viewpoints of how we want to compartmentalize the mediastinum. We chose this one because we found it to be the simplest. But you guys should be aware that there are other ways you can break this up.
And one thing to note about the anterior mediastinum on here is that it's confined by the trachea posteriorly, and superiorly, it's confined by the clavicles. So everything below the clavicles is in the anterior mediastinum. Everything above the clavicles on your PA or AP chest x-ray is most likely middle mediastinum or posterior mediastinum. So let's get to anterior mediastinum, and here's our first example. After you guys go through your approach, kind of tracing your structures, we're coming down here, everything looks okay. And right here is a little bit obscured. It's a little bit poking out, a little bit too wide, but let's look at our trachea. It looks pretty midline. So it's probably not something in the middle mediastinum, but that right there is definitely abnormal. It's either our anterior mediastinum or our posterior mediastinum,
Strong clue at the top of the screen.
that'll clue
Also,
you in.
a point about this chest x-ray too, you can see how that has a pretty well delineated border
Mhm.
and it's asymmetric.
Absolutely. And when we go to the lateral chest x ray here, we confirm that this is an anterior mediastinal mass because it's in front of that trachea. And what are some things that we have to worry about with anterior mediastinum? And those are the 5 T's. And the 5 T's stand for thymic cancer, teratoma, thyroid cancer, terrible lymphoma, which there's a bunch of different ones, and then the ascending thoracic aorta. Those are all the structures there that can be abnormal.
And a lot of these we will be following up with a CT scan so we can try and hone in on our diagnosis a little bit further. Let's move on to the middle mediastinum. We're going to go right to our lateral and we're going to draw our lines for you. So remember, that first line is anterior to the trachea behind the heart. And that second line is a line drawn 1 centimeter behind the anterior edge of the vertebral bodies. Let's talk about some anatomy. The first structure is going to be the trachea. The next structure is going to be our aortic arch and our descending aorta. After that is going to be our lymph nodes. Remember, the lymph nodes are actually in all our compartments, but classically we categorize them into the middle mediastinum. And our last structure that we're going to highlight is the esophagus. Like we discussed earlier with where we put structures into which compartments, different sources will say different things. We like to include the descending aorta into the middle mediastinum. Sometimes that's in the posterior mediastinum, but just so you guys are aware, structures can sometimes be described in other compartments.
Yeah, absolutely. And I also want to make a point here. The esophagus is something you will probably not ever see on a chest x ray, right? Because it's completely flat most of the time.
So, just a couple examples of middle mediastinal pathology. Your classic one is going to be this diffuse mediastinal widening, obviously a very concerning chest x-ray. We do see some
Yikes.
tracheal deviation there, which is a clue that maybe this is the middle mediastinum. This was an aortic dissection, so follow this up with the CT. Our next example is going to be a little bit more subtle. We can change the width of this chest x-ray so we can highlight it a little bit further. You can see an air bubble down there in the inferior portion of this chest x-ray. This person had a large hiatal hernia, and remember the esophagus is part of that middle mediastinum, so this is middle mediastinal pathology.
And last but not least, we have our posterior mediastinum. And the posterior mediastinum is everything paravertebral. So everything from that second line back to the posterior ribs, right? So that entire area on our lateral chest x ray is the posterior mediastinum in our classification system. Well, when we're looking at this PA chest x ray, we're going to stick to our are there many lung lesions approach. We're going to trace out our mediastinum. I don't see any widening. The trachea doesn't look deviated. So we're not thinking anterior or middle. And we're looking along the lungs and we see this area of increased density, this circular area in the apex of the right lung. And that would be concerning for a couple different things. And when we're thinking about the patient's age, we have to think, is this a young patient? And if it is, we have to think about tumors of nerves or nerve sheaths, like a neurofibroma or a schwannoma. And then if you're thinking about an older patient, you have to think about multiple myeloma or metastatic disease from things like prostate cancer, which can metastasize to the paravertebral area. And here's our CT of this same exact patient showing that there is indeed a posterior mediastinal or paravertebral mediastinal mass here. And that would be concerning for, which was diagnosed later, a schwannoma in that patient.
Let's move on to the hilum. Our hilar region, as we look at it on the chest x-ray, is essentially our pulmonary artery and vein. And you do have lymph nodes in this area, obviously, but on a normal chest x-ray, you're not going to be able to see those. We'll switch over to our pathology. Our first example is going to be our bilateral hilar lymphadenopathy. This is a patient who was diagnosed with sarcoidosis, and you can see how the hilar regions in that area are more dense and fluffy looking. The other example is an example of pulmonary artery hypertension. You can see a prominent pulmonary arterial trunk, and then those pulmonary vessels are also going to be larger and more engorged and denser.
Just keep in mind, clinical context is key in these cases. We're not diagnosing pulmonary hypertension based on a chest x ray. But if you have a morbidly obese person with obstructive sleep apnea for many years and you see this, you're like, okay, this is concerning for pulmonary hypertension. But again, this is not a diagnosis you can make just with a chest x-ray.
So let's highlight this a little bit further. First, we'll highlight the right ventricle for you, which again, that remember sits a little bit more anterior. And that blue line there is a prominent pulmonary trunk. And then the rest of the blue is our pulmonary vasculature, which is also larger and more engorged. If you've seen our PE lecture, we discussed something called a Fleischner sign. Fleischner sign is essentially prominent pulmonary vasculature, which then creates this sausage-like density in the hilar region. You can get that with a PE, or you can also get that with pulmonary hypertension. If we compare this to our normal, remember, you should have a nice pulmonary artery window that's highlighted by that diamond for you. And it's clear that in our abnormal chest x-ray, we completely lose that. Now, if we look at this patient's CT scan, this is an axial cut right in the middle of their chest. You can see how large that pulmonary trunk is compared to the ascending aorta. Our normal ratio should be around 1-to-1 or less than that. Usually the pulmonary trunk is going to be slightly smaller than our ascending aorta.
And in this case, that pulmonary trunk is massive. Of course, we can't talk about a mediastinal lecture without talking about pneumomediastinum, or air in the mediastinum. And how that happens is from, most of the time, esophageal perforation. And that's exactly what this AP chest x-ray is, because these patients are very sick. They're toxic appearing. You're not asking these patients to walk down to chest x-ray to get a PAA and lateral. It's just not possible. Unfortunately, one view is the only view we can get with pneumomediastinum.
One view is the only view.
So when we're looking at this chest x-ray, there's a ton of different findings here, but some of the most prominent are going to be our pneumopericardium, which is this air right here along the pericardium. We also see this paravertebral linear lucency kind of streaking upward, which again is cluing us into this pneumomediastinum. We also see the paratracheal lucencies, which again is air along the trachea. And then something that's really interesting and very rare on this AP chest x-ray is the V sign. And V sign happens when you get a posteromedial esophageal rupture. And what happens is the air gets trapped between the diaphragm and the medial parietal pleura of the lung on both sides. And it gives this V kind of shape going up into the mediastinum. So that's a very rare finding. And again, the V sign. And if we zoom in a little bit further, I think it's really important to just highlight all of these lucencies, or these linear streaks kind of going up the neck and then into the soft tissue of the neck. It's really important to look at your soft tissue while you're looking at your thorax and while you're looking at your mediastinum when we're doing our systematic approach to the chest x-ray. So all of this dark, or all this lucency right here, that's all subcutaneous emphysema, or air underneath the skin. This patient would have crepitus, all of the physical exam findings consistent with pneumomediastinum. And here's a CT scan of that same exact patient. As we're going up from the diaphragm, we already see these black areas, which is consistent with air, pneumopericardium, almost compressing the heart. Sometimes that can cause tamponade. And then we have the dark areas kind of just following the trachea all the way up, and the esophagus up into the soft tissue of the neck and upper borders of the trapezius. This is just bad, just real bad.
That's a diagnosis of bad. So in review, remember to have your systematic approach. When it comes to mediastinum, our focus is going to be on tracing our structures. We're going to be looking for masses, widening, deviation, obscuration of borders, and we're going to be checking for air. For pneumomediastinum, don't forget to pay close attention into the neck and soft tissues. Our anterior mediastinum is going to be from the sternum, a line drawn in front of the trachea and behind the posterior aspect of the heart. Our 5 T's are going to be the thymoma, thyroid cancer, teratoma, terrible lymphoma, and our ascending thoracic aorta. Our middle mediastinum is going to be from that line to our posterior line, which is going to be 1 centimeter behind the anterior edge of the vertebral bodies. Some of those structures are going to be our aortic arch, our descending aorta, our esophagus, and our lymph nodes. Our posterior mediastinum is going to be everything behind that posterior line, or our paravertebral area. In our younger population, we're going to be concerned about nerve tumors, and our older population will be concerned about METs, multiple myeloma. Okay, everyone, that is mediastinum. Thank you for stopping by. We'll see you in the next video.